the 30th of May of 2013, I had the privilege of attending the operating theatre of Professor Hugues Dufour in Montpellier. Following the operations, I had the opportunity to discuss with him his philosophy for managing patients with low-grade gliomas. This is a summary, my summary of the discussions that I had with Professor Dufour. As you know, there's a great deal of controversy regarding management of low-grade gliomas. I asked Professor Dufour what was his primary strategy for managing such lesions. He mentioned that his strategy is surgical resection. This is because he doesn't believe in surveillance, because low-grade gliomas are not stable lesions. They grow and they grow slowly. This may not be picked up on surveillance MRI scan. And his other point is that low-grade gliomas are not benign lesions. They can undergo, or they do undergo, malignant transformation. So his belief is that it is better to resect them. Professor Dufour undertakes functional mapping even when he operates on a low-grade glioma on the non-dominant side. The reason he gives for this is that in his experience he has noted that even the non-dominant side contributes to language function. If the lesion being resected is a benign lesion, one would expect only for that lesion to be resected. In the case of low-grade gliomas, many surgeons will also remove an additional rim of what would appear to be normal brain surrounding the lesion. However, Professor Dufour undertakes what he calls supramarginal resection. What he does is he undertakes functional mapping to identify eloquent brain that is adjacent to the lesion. Then he resects the lesion as well as extends the resection up to, but not including, the eloquent area. This way, he tries to remove as much of the infiltrative tumor that is not apparent on the MRI scan. And he attributes the longer median survival of his patients with low-grade gliomas for supramarginal resection that he undertakes safely. When undertaking awake craniotomy, neurosurgeons perform cortical functional mapping. Professor Dufour also performs subcortical stimulation and functional mapping. There has been controversy regarding whether subcortical stimulation is reliable. Professor Dufour demonstrated that when he performs subcortical stimulation in awake patients, he he can induce temporary neurological deficits. His philosophy is that subcortical stimulation is not a substitute for knowing subcortical anatomy, the anatomy of the various tracts. He uses subcortical stimulation to confirm his anatomical identification of the various tracts. Professor Dufour emphasizes that neuro-oncological surgeons would need to know cortical subcortical anatomy and anatomical and functional correlates. He thinks this is fundamental to undertaking safe neuro-oncological surgery, particularly in low-grade gliomas. Professor Dufour speaks of taking advantage of cortical plasticity to maximize the extent of lesion resection. What does he mean by plasticity? He states that language function is subserved by different areas within the cerebral cortex. However, one area is dominant. If a lesion that involves this dominant area, then as its function decreases, the supplementary areas take over the function to subserve speech. He uses this phenomena to resect as much of the tumor that he can without endangering speech. Then, as the supplementary areas take over more of the speech function, he goes back in again and with functional mapping tries to resect more of the residual tumor from the last operation. This way, he maximizes the extent of resection, taking advantage of the plasticity of the other areas of the cortex that subserve speech. Insular tumors may be approached through the sylvian fissure or transcortically with subpile resection. The transsylvian approach is technically very challenging. There's also a risk of causing injury to the middle cerebral artery branches as well as vasospasm. Professor Dufour undertakes transcortical subpile resection. He considers that resection through the opercula is safer in the hands of most neurosurgeons than transsylvian approach. By keeping subpile, he avoids any hemorrhages that require bipolar coagulation. Professor Dufour does utilize intraoperative ultrasound to delineate the gross margin between the tumor and the brain. He uses ultrasound, but he doesn't use it as stereotactic ultrasound. And it's not used as a live ultrasound guided resection. The ultrasound is used intermittently to find the brain tumor interface. So this now brings me to conclude what I thought was the philosophy of Professor Dufour in tackling low-grade gliomas. You might wish to contact Professor Dufour directly if you would like further clarification or advice. Thank you very much for your kind attention. Wishing you a good evening. Bye for now.